Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Welcome to this focused discussion on the critical aspects of antiepileptic drugs. This curriculum explores the intricate world of these essential medications, examining their diverse mechanisms of action and, importantly, their toxicological profiles. Our goal is to provide a comprehensive understanding of how these agents function, the complexities that can arise in overdose situations, and the appropriate management strategies to ensure patient safety and optimize outcomes. We will carefully examine specific antiepileptic drugs, including valproic acid, phenytoin, carbamazepine, oxcarbazepine, lamotrigine, and levetiracetam. The discussion will highlight their unique pharmacokinetic characteristics, clinical signs of toxicity, and evidence-based approaches to treatment. This module aims to equip you with the knowledge needed to address the challenges associated with the toxicology of these drugs in clinical practice. Here are 10 brief learning objectives designed to guide your study of antiepileptic drug toxicology, emphasizing crucial knowledge for healthcare professionals. First, you should be able to describe the diverse mechanisms of action employed by various antiepileptic drugs. These include sodium channel blockade, calcium channel blockade, and gamma-aminobutyric acid potentiation. Next, you should be able to explain the proposed mechanisms of hyperammonemia induced by valproic acid. This involves detailing the roles of mitochondrial dysfunction, carnitine depletion, and interference with the urea cycle. Additionally, it is important to differentiate between intravenous and oral administration of L-carnitine and to recommend appropriate dosing strategies for patients with toxicity from valproic acid, whether they are symptomatic or asymptomatic. You should also analyze the unique pharmacokinetic properties of phenytoin, particularly its dose-dependent metabolism, known as zero-order kinetics, and its high protein binding. These features relate to its clinical manifestations of toxicity. Understanding management strategies for phenytoin toxicity is crucial. These strategies include supportive care and specific interventions to manage adverse effects on the cardiovascular system and local injection-related complications. Furthermore, you should be able to describe the primary mechanisms of action, complex pharmacokinetics, including autoinduction and active metabolites, and the major toxicological effects of carbamazepine. It is also essential to compare and contrast the pharmacodynamic, pharmacokinetic, and toxicity profiles of carbamazepine and oxcarbazepine. Focus on differences in their metabolism, active metabolites, and incidences of hyponatremia. You need to identify the key mechanisms contributing to toxicity from lamotrigine, such as cardiac sodium channel blockade. Recognize the potential for severe hypersensitivity reactions and paradoxical seizures. Developing a comprehensive management plan for lamotrigine overdose is important. This plan should include supportive care, gastrointestinal decontamination, and specific treatments for cardiac dysrhythmias and hypersensitivity reactions. Finally, you should be able to describe the typical clinical presentation and management approach for overdose of levetiracetam. While it generally has a favorable safety profile, there is a potential for central nervous system depression, especially in cases of massive ingestion or in patients with renal impairment. The mechanisms of action of antiepileptic drugs involve various processes that help control seizure activity. One key mechanism is the blockade of sodium channels. This action prevents voltage-gated sodium channels from opening, thereby reducing the release of the excitatory neurotransmitter glutamate. By doing so, neuronal excitability decreases and the spread of seizures is hindered. Several drugs, including carbamazepine, eslicarbazepine, lamotrigine, oxcarbazepine, phenytoin, refinamide, topiramate, valproic acid, and zonisamide operate through this mechanism. Another important mechanism involves the blockade of calcium channels. This reduces the release of excitatory neurotransmitters such as glutamate as well. Different drugs target various types of calcium channels. For instance, gabapentin and pregabalin bind to the alpha-2 delta-1 subunit of high-voltage calcium channels. Levetiracetam mainly inhibits N-type calcium channels, although this is not its primary mode of action. Lamotrigine inhibits both N-type and P/Q-type calcium channels, while topiramate inhibits L-type channels. Zonisamide reduces neuronal pacemaker current by inhibiting T-type calcium channels. Some drugs directly inhibit the action of excitatory neurotransmitters. Perampanel acts as a non-competitive antagonist of certain receptor sites for excitatory neurotransmitters, such as AMPA receptors. Topiramate inhibits kainate receptors, and valproic acid blocks NMDA receptors. The potentiation of gamma-aminobutyric acid is another significant mechanism. This inhibitory neurotransmitter's concentration can be increased within synapses by several approaches. Vigabatrin irreversibly inhibits gamma-aminobutyric acid transaminase, the enzyme responsible for gamma-aminobutyric acid breakdown. Valproic acid has similar effects. Tiagabine inhibits the gamma-aminobutyric acid transporter GAT1, preventing gamma-aminobutyric acid reuptake into presynaptic neurons. Certain drugs also act by binding to specific synaptic proteins. For example, levetiracetam binds to synaptic vesicle glycoprotein 2A, inducing a conformational change that inhibits glutamate release from the presynaptic neuron. Lastly, some medications open voltage-gated potassium channels. Ezogabine, for example, causes these channels to open, resulting in neuronal hyperpolarization and reduced excitability. It is noteworthy that some antiepileptic drugs can exert multiple mechanisms of action, with valproic acid and topiramate serving as prime examples. Proposed mechanisms for hyperammonemia induced by valproic acid include mitochondrial dysfunction, depletion of carnitine, and interference with the urea cycle. Carnitine plays a vital role in treating hyperammonemia caused by valproic acid, as it helps address the metabolic imbalances induced by the drug and supports the body's natural process of detoxifying ammonia. In terms of restoring carnitine balance, valproic acid is metabolized mainly through a process called beta oxidation. This process consumes large amounts of carnitine, an amino acid essential for transporting fatty acids into mitochondria where they are used for energy production. The depletion of carnitine resulting from this process can impair fatty acid metabolism and may cause a shift in valproic acid metabolism towards a less efficient and potentially more toxic pathway known as omega oxidation. Supplementing with carnitine helps replenish its depleted stores, thereby promoting a favorable balance between beta oxidation and omega oxidation, and potentially reducing the risk of hyperammonemia. Promoting beta oxidation is essential for the primary pathway of valproic acid metabolism, which occurs within the mitochondria. L-carnitine plays a crucial role as a transporter, facilitating the entry of valproic acid into the mitochondria for beta oxidation. Ensuring adequate levels of carnitine through supplementation supports efficient beta oxidation, thereby reducing the reliance on omega oxidation. When carnitine levels are low, the metabolism of valproic acid can shift towards omega oxidation, a process that takes place in the endoplasmic reticulum. Omega oxidation produces potentially toxic metabolites such as 4N-valproate. These metabolites, along with decreased levels of N-acetylglutamate, can interfere with the function of carbamoyl phosphate synthase, a key enzyme in the urea cycle responsible for detoxifying ammonia. By promoting beta oxidation and restoring balance in carnitine levels, supplementation with L-carnitine indirectly reduces the dependence on omega oxidation. This shift minimizes the production of toxic metabolites and lessens their impact on the urea cycle, ultimately supporting better detoxification processes and reducing potential adverse effects associated with valproic acid metabolism. Supporting the urea cycle, which is the primary pathway for ammonia detoxification in the liver, is essential for maintaining health. The enzyme carbamoyl phosphate synthetase plays a crucial role in the initial step of this cycle by incorporating ammonia into urea for excretion. Metabolites produced through omega oxidation of valproic acid can inhibit this enzyme, impairing the ability of the urea cycle to eliminate ammonia effectively. By reducing the production of these inhibitory metabolites, L-carnitine helps to support the proper functioning of the urea cycle indirectly. In addition to supporting the urea cycle, studies have demonstrated that supplementation with L-carnitine can lead to a reduction in ammonia concentrations in individuals taking valproic acid. Although the exact mechanism is not yet fully understood, it is believed that the combined effects of promoting fatty acid oxidation, decreasing omega oxidation, and supporting the urea cycle contribute to an improvement in the body's ability to eliminate ammonia. L-carnitine supplementation in cases of valproic acid-induced hyperammonemia helps to correct the metabolic imbalances caused by valproic acid. It replenishes depleted stores of carnitine, promotes the efficient and less toxic process of beta oxidation, and reduces dependence on the potentially harmful omega oxidation pathway. Additionally, it indirectly supports the proper functioning of the urea cycle, which ultimately leads to improved detoxification of ammonia and a reduction in ammonia levels. This process highlights the interconnected nature of our metabolic systems. For example, within the citric acid cycle, alpha-ketoglutarate is converted into glutamate. This amino acid serves as a precursor for gamma-aminobutyrate, among other molecules. Both stimulatory and inhibitory neurotransmitters derived from glutamate can be metabolized and rely on the urea cycle for further elimination. If this process is disrupted, an imbalance of neurotransmitters may occur, which can precipitate seizures or coma in patients experiencing toxicity from valproic acid. This intricate interaction exemplifies the complexity of our physiological systems. It also underscores why a particular treatment might effectively lower a specific measurement, such as ammonia levels, but may not necessarily improve the patient's overall clinical condition. Intravenous L-carnitine is generally preferred over oral L-carnitine, especially in acute clinical settings. This preference is mainly because of the significantly higher bioavailability of intravenous L-carnitine compared to the oral route. When administered intravenously, L-carnitine bypasses the first-pass metabolism in the liver and avoids absorption limitations associated with the gastrointestinal tract. As a result, it is delivered quickly and almost completely into the systemic circulation. After a dose of 2 grams, the peak serum concentration of L-carnitine following intravenous administration is approximately 1,000 micromoles per liter. In contrast, the same oral dose produces peak concentrations ranging from only 15 to 70 micromoles per liter. This substantial difference in bioavailability has important implications for the therapeutic effectiveness and clinical usefulness of L-carnitine. In situations that demand rapid correction of L-carnitine deficiency or immediate treatment of toxicity, the intravenous route is especially important. Such conditions include acute metabolic disorders, hyperammonemia induced by valproic acid, liver toxicity, metabolic acidosis, and encephalopathy. Using the intravenous method ensures that therapeutic levels of L-carnitine are achieved quickly and consistently, which is crucial for effective management. Patients who exhibit symptoms often require intravenous L-carnitine, which is the preferred method of treatment for these individuals. Conversely, for patients who do not show symptoms and are not in an acute state of illness, oral L-carnitine may be a sufficient form of therapy. This distinction underscores the importance of carefully assessing the patient's clinical presentation and determining the urgency of the treatment required. Such evaluation helps healthcare providers choose the most appropriate route of administration to ensure effective and timely management. The oral absorption of L-carnitine becomes saturated after a certain dose, approximately 6 grams. This saturation means that increasing the oral dose beyond this point does not result in a proportional increase in the amount of L-carnitine absorbed by the body. As a result, administering L-carnitine intravenously may be necessary in situations where high and consistent levels are required, since intravenous delivery can bypass the saturation limitation associated with oral intake. The dosing of L-carnitine for toxicity caused by valproic acid involves specific administration guidelines, particularly for patients showing symptoms related to toxic effects. Intravenous L-carnitine is recommended for patients experiencing symptoms such as high levels of ammonia in the blood, liver damage, metabolic acidosis, or neurological disturbances like encephalopathy. The recommended initial or loading dose is 100 milligrams per kilogram of body weight, administered intravenously over a period of 30 minutes. The maximum dose during this initial phase should not exceed 6 grams. Following the loading dose, a maintenance dose of 15 milligrams per kilogram can be given every 6 hours, with each dose administered over a span ranging from 10 to 30 minutes. For children, a daily dose of 500 milligrams per kilogram is suggested, with no established maximum dose. However, a total daily dose of 6 grams is considered reasonable after the initial intravenous loading dose. The rationale for using the intravenous route is to ensure rapid and complete delivery of L-carnitine into the bloodstream. This method bypasses any absorption issues associated with oral administration. Such prompt delivery is especially crucial in emergency situations where quickly correcting a deficiency of L-carnitine can help mitigate the toxic effects of valproic acid. Oral L-carnitine is generally sufficient for patients who are not acutely ill and do not show symptoms of valproic acid toxicity. The typical recommended oral dose ranges from 50 to 100 milligrams per kilogram of body weight per day, with a maximum of 3 grams daily. This dosage is usually divided into multiple doses throughout the day. For adults, this can be achieved by taking 3 tablets of 330 milligrams each 3 times a day. In asymptomatic patients, the slower absorption and lower bioavailability of oral L-carnitine may not be of significant concern. Oral administration offers a more convenient and practical option, especially for long-term management or preventive use in individuals at risk of developing toxicity caused by valproic acid. Phenytoin is an antiepileptic medication that has been in use since 1938. When taken orally, it is generally considered safe. However, intravenous administration poses a higher risk of toxicity due to the presence of the propylene glycol diluent. Regarding its pharmacokinetics and metabolism, the absorption of phenytoin after oral intake is slow and often incomplete, which can be especially problematic in overdose situations. The peak serum concentrations are typically reached within 3 to 12 hours following a single dose. In terms of distribution, phenytoin disperses widely throughout the body. It has a volume of distribution of approximately 0.6 liters per kilogram of body weight. The drug rapidly reaches equilibrium between the plasma and the central nervous system, typically within 10 minutes, and between the plasma and the myocardium, usually within 30 to 60 minutes. Phenytoin is highly protein-bound, with approximately 90% attached primarily to albumin. Only the unbound or free fraction of the drug is pharmacologically active. Phenytoin is mainly metabolized by liver enzymes in the cytochrome P450 family, especially the enzymes CYP2C9 and CYP2C19. These enzymes convert phenytoin into inactive metabolites. Less than 5% of the drug is excreted unchanged in the urine. The rate at which phenytoin is metabolized depends on the dose. At low concentrations, the drug is eliminated through a process called first-order metabolism, meaning a specific percentage of the drug is broken down each unit of time. However, at higher concentrations, including those within the therapeutic range, metabolism becomes saturated. This results in zero-order elimination, where a fixed amount of the drug is metabolized per unit of time. This saturation can significantly extend the drug's half-life, meaning it remains in the body longer. The mechanisms of toxicity of phenytoin involve several processes. Primarily, phenytoin prolongs the inactivation of neuronal sodium channels, which inhibits the release of excitatory neurotransmitters. This action is particularly significant in neurons that fire at high frequencies and is associated with the drug's anticonvulsant properties. Additionally, phenytoin inhibits the reuptake of adenosine, a neuromodulator, resulting in increased levels of adenosine in the extracellular space and thereby enhancing its anticonvulsant effects. At higher concentrations, phenytoin can also affect the function of potassium channels by delaying the activation of outward potassium currents in neurons. This delay prolongs the refractory period of neurons, further contributing to its anticonvulsant activity. The dose, duration, route, and rate of administration all influence the clinical presentation of phenytoin toxicity. It is important to understand that the relationship between phenytoin levels and clinical symptoms is not always straightforward. Several factors, including individual patient characteristics, underlying medical conditions, and the use of other medications, can affect how toxicity manifests. Therefore, careful clinical assessment and ongoing monitoring are essential. Treatment decisions should not rely solely on plasma concentration values. The therapeutic plasma concentration range for phenytoin is typically between 10 and 20 micrograms per milliliter, which corresponds to 20 to 40 micromoles per liter. The free form of phenytoin, which is unbound to plasma proteins, generally has a therapeutic range of 1 to 2 micrograms per milliliter or 2 to 4 micromoles per liter. It is crucial to note that individual responses to phenytoin vary. Some patients may require higher drug levels to achieve seizure control, while others may experience toxicity at lower levels. Nystagmus is an involuntary eye movement that is often the earliest sign of toxicity caused by the medication phenytoin. This symptom typically appears when the drug's concentration in the blood reaches or exceeds 20 micrograms per milliliter, which is equivalent to 40 micromoles per liter. At the initial stages, nystagmus may only be noticeable during forced lateral gaze. However, as the drug concentration increases, the involuntary eye movements can become spontaneous and more evident. An increased concentration of phenytoin, specifically greater than 30 micrograms per milliliter or 60 micromoles per liter, is commonly associated with ataxia and poor coordination. These symptoms suggest cerebellar and vestibular dysfunction. Additionally, signs of central nervous system depression, such as confusion, dizziness, lethargy, difficulty speaking clearly, and memory impairment, may also be observed. Severe toxicity related to phenytoin occurs when blood concentrations exceed 50 milligrams per liter. Such elevated levels are associated with a range of more serious symptoms. These symptoms include lethargy and slurred speech, along with motor and neurological impairments. Patients may also experience paralysis of the eye muscles, known as ophthalmoplegia, and rapid, involuntary eye movements called opsoclonus. Additionally, focal neurological deficits can be observed in affected individuals. Seizures can paradoxically occur in cases of phenytoin toxicity, although this is a rare event. Most patients who experience seizures tend to have plasma drug concentrations exceeding 30 micrograms per milliliter, which is equivalent to 60 micromoles per liter. Nonetheless, such seizures are usually brief and generalized. When seizures do occur, they should prompt healthcare providers to investigate other possible causes. In patients with low albumin levels or conditions that alter protein binding, monitoring the free phenytoin concentration provides a more accurate assessment of toxicity. Symptoms typically manifest when the free drug level reaches or exceeds 2 micrograms per milliliter or 4 micromoles per liter. Symptoms tend to become consistently severe at concentrations greater than 5 micrograms per milliliter or 10 micromoles per liter. Other considerations include the potential for cardiovascular toxicity associated with the administration of phenytoin. When administered intravenously, rapid infusion can lead to serious heart-related side effects such as low blood pressure, slow heart rate, delays in electrical conduction within the heart, and even life-threatening conditions like cardiac arrest, ventricular tachycardia, and ventricular fibrillation. These adverse effects are mainly caused by the propylene glycol diluent used in the medication, which can depress heart function and cause blood vessels to dilate. It is important to note that the maximum infusion rate recommended is 50 milligrams per minute. However, patients often cannot tolerate rates higher than 20 milligrams per minute. In contrast, oral administration of phenytoin generally does not cause significant cardiac toxicity, even in cases of overdose. Vascular and soft tissue injuries can occur as a result of various medical procedures or adverse reactions. For instance, intramuscular injections may cause complications such as hematomas, sterile abscesses, and muscle tissue death at the injection site. Intravenous extravasation can lead to severe tissue damage, including skin and soft tissue necrosis, compartment syndrome, gangrene, the need for amputation, and the breakdown of muscle tissue known as rhabdomyolysis. There are also adverse effects that are not related to dosage. One common side effect of long-term therapy with the anticonvulsant medication phenytoin is gum enlargement, which affects up to 20% of patients. Additionally, a rare and unpredictable reaction called anticonvulsant hypersensitivity syndrome may occur. This syndrome is characterized by symptoms such as fever, skin rashes, blood disorders, and inflammation of the liver, typically appearing within the first few months of treatment. Treatment for phenytoin toxicity primarily involves supportive care. Activated charcoal may be considered in the early stages within 1 hour of oral ingestion to help reduce absorption. However, its impact on clinical outcomes remains uncertain. Hemodialysis and hemoperfusion are generally ineffective for removing phenytoin, owing to the drug's high protein-binding properties. Seizures related to phenytoin toxicity are rare, but if they occur, benzodiazepines or barbiturates can be used to manage them. During intravenous administration, hypotension can often be managed by discontinuing the infusion and administering isotonic crystalloid solutions. In cases of bradyarrhythmias, atropine and temporary pacing may be necessary. Fosphenytoin, a prodrug of phenytoin, offers certain advantages over intravenous phenytoin. It is more water-soluble, which reduces the risk of tissue irritation and extravasation injury, and it has a lower likelihood of causing hypotension and other adverse effects associated with the propylene glycol diluent used with phenytoin. The maximum intravenous infusion rate for fosphenytoin is 150 milligrams per minute, and it can also be administered intramuscularly, although the volume makes this less practical. Despite its benefits, fosphenytoin can still cause pruritus and hypotension if administered too rapidly intravenously. Therefore, blood pressure and cardiac monitoring are recommended during intravenous loading. Carbamazepine is an antiepileptic medication that has a chemical structure similar to that of tricyclic antidepressants. It is commonly used to treat epilepsy, trigeminal neuralgia, and several other conditions. However, like many drugs used for neurological disorders, carbamazepine carries a risk of complications during pregnancy. These complications can include preeclampsia, premature births, spontaneous abortions, and stillbirths. The focus here is on the toxicology of carbamazepine. The drug exerts its effects through multiple mechanisms. The primary mechanism involves the blockade of voltage-gated sodium channels. This action stabilizes neurons that are hyperexcited, thereby preventing the propagation of potentially harmful excitatory impulses. Additionally, carbamazepine acts as an antagonist at various receptor sites within the nervous system. It blocks acetylcholine receptors, including both muscarinic and nicotinic types, as well as N-methyl diaspartate receptors and adenosine receptors in the central nervous system. These receptor antagonism actions also contribute to the toxic effects observed in cases of overdose. The pharmacokinetics of carbamazepine play a significant role in its toxicity. Its absorption after ingestion is slow and unpredictable, potentially taking up to 100 hours to reach peak concentrations. controlled-release formulations of the drug are absorbed even more slowly. Carbamazepine is lipophilic, meaning it dissolves in fats and distributes rapidly throughout all tissues in the body. It can also cross the placenta and is secreted into breast milk. The drug is primarily metabolized in the liver through the cytochrome P450 enzyme system, mainly by the enzyme known as CYP3A4. One of its major metabolites is carbamazepine 10,11 epoxide, which is pharmacologically active. This metabolite contributes to both the therapeutic effects and potential toxicity of the medication. The ratio of this active metabolite to the original drug increases during overdose, influencing the clinical presentation of toxicity. Furthermore, carbamazepine uniquely induces its own metabolism. This self-induction occurs after 2 to 4 weeks of continuous use and results in a decrease in the drug's elimination half-life, necessitating close monitoring during therapy. The toxicokinetics of carbamazepine involve several complex factors. Its absorption is often delayed and irregular, especially when controlled-release formulations are used, leading to a delay in reaching peak serum concentrations and resulting in prolonged drug exposure. An active metabolite called carbamazepine 10,11 epoxide or carbamazepine epoxide accumulates in the body and contributes to toxicity. This metabolite exhibits both anticonvulsant and neurotoxic effects, and higher concentrations are typically observed in overdose situations. Additionally, carbamazepine and its metabolite normally bind strongly to proteins in the blood. However, during overdose, the fraction of unbound or active drug increases, which allows more of the drug to cross into the central nervous system, thereby enhancing its toxic effects. Drug interactions involving carbamazepine are numerous and can significantly impact its pharmacokinetics and toxicity. For instance, drugs that inhibit the enzyme cytochrome P453A4, such as certain antibiotics called macrolides, antifungal agents known as azoles, and medications like calcium channel blockers, can increase the levels of carbamazepine in the body. This elevation can potentiate toxicity. Conversely, drugs that induce the activity of cytochrome P453A4, including phenytoin, phenobarbital, and rifampin, can decrease carbamazepine concentrations, thereby reducing its therapeutic efficacy. Additionally, co-administration with drugs that inhibit an enzyme called epoxide hydrolase, such as valproic acid and lamotrigine, can lead to elevated levels of carbamazepine epoxide, a metabolite that can contribute to adverse effects. The clinical presentation of carbamazepine toxicity is diverse and involves multiple organ systems. Central nervous system toxicity often manifests as neurologic disturbances, including nystagmus, ataxia, seizures such as status epilepticus, and coma. Children are particularly susceptible, experiencing higher incidences of dystonic reactions, chorioathetosis, and seizures compared to adults. In terms of cardiovascular toxicity, the anticholinergic effects of carbamazepine frequently dominate during the early stages of poisoning. These effects can cause delirium, agitation, rapid heartbeat, intestinal paralysis, and urinary retention. Although carbamazepine shares structural similarities with tricyclic antidepressants, significant sodium channel blockade and cardiovascular toxicity, such as prolongation of the QRS complex, are less common than with tricyclic antidepressants. Nevertheless, heart block and slow heart rate can occur even at therapeutic drug concentrations. Additionally, sinus tachycardia and low blood pressure are frequently observed. Respiratory toxicity can lead to serious conditions such as respiratory depression, coma, and the need for intubation, especially in cases of severe overdose. In addition to respiratory issues, various other organ systems may be affected. For example, hyponatremia, a condition characterized by low sodium levels in the blood, can occur due to increased secretion of antidiuretic hormone, a condition known as syndrome of inappropriate antidiuretic hormone secretion, or due to increased sensitivity of peripheral osmoreceptors to this hormone. Chronic overdose of carbamazepine, a medication used to treat seizures, can also result in leukopenia, which is a reduction in white blood cell count. Regarding hepatic toxicity, transient elevations in liver enzyme levels can happen, particularly during the first few months of treatment. Another serious but rare adverse reaction is anticonvulsant hypersensitivity syndrome. This multi-system disorder can be potentially fatal and is characterized by symptoms such as fever, skin rash, swelling of lymph nodes, and involvement of multiple organs, including the liver, lungs, and kidneys. It is believed that this syndrome is related to the formation of reactive arene oxide metabolites during the drug's metabolism. The management of carbamazepine overdose is primarily supportive. Airway protection is essential, and healthcare providers should ensure adequate airway and ventilation support if necessary. Gastrointestinal decontamination can be considered, especially in the early stages after oral ingestion, by administering activated charcoal to reduce absorption. Multiple doses of activated charcoal may be more effective in this process. Seizures caused by overdose should be managed with medications such as benzodiazepines and barbiturates to control the seizure activity. Hypotension, if present, should be treated with intravenous fluids and vasopressor medications to maintain blood pressure. Electrolyte imbalances, particularly hyponatremia, can be addressed by restricting fluid intake and correcting electrolyte disturbances. In severe cases of toxicity, or if there is a prolonged coma or rising carbamazepine levels despite multiple doses of activated charcoal, enhanced elimination techniques such as hemodialysis and hemoperfusion may be considered. However, these methods are generally not highly effective due to the drug's high protein binding properties. Oxcarbazepine is a structural analog of carbamazepine with a similar mechanism of action and toxicity profile. However, its active metabolite, 10-monohydroxycarbamazepine, is formed more rapidly, which may potentially limit toxicity in cases of overdose. The management of oxcarbazepine overdose is primarily supportive with the consideration of activated charcoal administration for gastrointestinal decontamination. Extracorporeal elimination techniques do not appear to significantly enhance the clearance of the drug. When comparing and contrasting carbamazepine and oxcarbazepine, it is important to note that both are structurally similar antiepileptic drugs. They share comparable pharmacodynamic and pharmacokinetic profiles. Both medications are effective in treating various types of seizures. Understanding their similarities and differences is essential for optimizing therapeutic management. The pharmacodynamics of carbamazepine and oxcarbazepine involve their mechanisms of action in controlling seizures. Both drugs primarily work by blocking voltage-gated sodium channels in neurons. This action stabilizes hyperexcited neuronal membranes and prevents the repetitive firing that can lead to seizures. Carbamazepine has additional mechanisms of action. It inhibits the reuptake of adenosine, which enhances its inhibitory effects on neurotransmitter release. Furthermore, it acts as an antagonist at receptors for acetylcholine, including both muscarinic and nicotinic types, as well as at N-methyl diaspartate receptors and central adenosine A1 receptors. These additional mechanisms extend its therapeutic effects, but can also contribute to toxic side effects. Oxcarbazepine functions as a prodrug. It is rapidly metabolized into its pharmacologically active metabolite, 10-monohydroxycarbamazepine. This active metabolite is responsible for the anticonvulsant effect seen with oxcarbazepine. The pharmacokinetics of both drugs involve their absorption, metabolism, and elimination processes. Both medications are well absorbed after oral administration. However, the absorption of carbamazepine is slow and unpredictable. It can take up to 100 hours to reach peak concentrations, especially when using controlled-release formulations. In contrast, oxcarbazepine is absorbed more rapidly and completely. Regarding metabolism, carbamazepine is mainly processed in the liver by the enzyme cytochrome P453A4. Its primary metabolite is carbamazepine 10,11-epoxide, which contributes to both the therapeutic effects and potential toxicity of the drug. Oxcarbazepine is also extensively metabolized in the liver, but is primarily converted swiftly into a metabolite called monohydroxy derivative through reduction and glucuronidation. In terms of enzyme interactions, carbamazepine significantly induces its own metabolism as well as the metabolism of other drugs, which results in a reduction of its elimination half-life over time. Oxcarbazepine and its metabolite have minimal effects on cytochrome P450 enzymes, but can induce glucuronidation processes. When it comes to elimination, carbamazepine initially has a half-life ranging from 25 to 65 hours, but decreases to 12 to 17 hours with long-term use due to autoinduction of its metabolism. Oxcarbazepine has a much shorter half-life of about 2 hours, while its metabolite remains in the system for approximately 8 to 15 hours. Toxicity and overdose from both carbamazepine and oxcarbazepine can affect several body systems, primarily the central nervous system, cardiovascular system, and respiratory system. In the central nervous system, overdose of either drug can lead to depression, which may result in symptoms such as drowsiness, loss of coordination, abnormal eye movements, confusion, and even coma. Carbamazepine has a higher likelihood of inducing seizures, including severe seizures known as status epilepticus, likely due to its multiple mechanisms of action and the accumulation of its active metabolite. Regarding the cardiovascular system, both drugs can cause an increase in heart rate and a decrease in blood pressure, mainly attributable to anticholinergic effects. Carbamazepine, because of its structural similarity to certain antidepressant medications, has a greater potential to cause abnormal heart conduction, although such effects are relatively rare. In comparison, overdoses of oxcarbazepine less frequently result in serious cardiovascular complications, possibly due to the rapid formation of a metabolite that limits the parent drug's direct effects. The respiratory system can be significantly affected in cases of overdose, with respiratory depression being a serious concern, especially in severe cases involving coma. Both carbamazepine and oxcarbazepine can cause hyponatremia, a condition characterized by low sodium levels in the blood. This adverse effect can be severe, and oxcarbazepine is associated with a higher incidence of hyponatremia, occurring in up to 29.9% of patients. For gastrointestinal decontamination in cases of overdose, activated charcoal is recommended to reduce drug absorption. Multiple doses of activated charcoal may be more effective, particularly for carbamazepine, because of its slow and unpredictable absorption. In terms of enhanced elimination, carbamazepine's high protein binding limits the effectiveness of hemodialysis and hemoperfusion, although these methods may still be considered in severe cases. Extracorporeal elimination techniques are not recommended for oxcarbazepine, as they do not appear to significantly improve the clearance of the drug or its active metabolite, which is known as MHC. Lamotrigine exerts its therapeutic and toxic effects through interactions with various ion channels and neurotransmitter systems. It primarily acts by binding to voltage-gated sodium channels when they are in their inactive state. This binding inhibits the release of glutamate, an excitatory neurotransmitter, and prevents the propagation of neuronal depolarizations, thereby effectively terminating seizures. Additionally, lamotrigine inhibits presynaptic voltage-gated calcium channels, specifically the N-type and P/Q-type channels. By inhibiting these calcium channels, lamotrigine further reduces glutamate release, contributing to its anticonvulsant properties. Beyond these primary actions, lamotrigine also has weaker effects on other targets, including the serotonin type 3 receptor and the enzyme dihydrofolate reductase. These additional interactions may play a role in some of its side effects. Understanding the pharmacokinetics of lamotrigine is essential for comprehending its potential toxicity. When taken orally, lamotrigine is rapidly and completely absorbed by the body, with an estimated bioavailability of approximately 98%. Once absorbed, the medication is distributed throughout the body, with a volume of distribution ranging from 0.9 to 1.3 liters per kilogram of body weight. About 55% of lamotrigine in the bloodstream is bound to plasma proteins. The drug is primarily metabolized in the liver through a process called glucuronidation, which results in the formation of inactive metabolites. The elimination half-life of lamotrigine, or the time it takes for half of the drug to be removed from the body, ranges between 24 and 37 hours. Most of the metabolites produced during metabolism are excreted from the body through urine. Lamotrigine's metabolism can be affected by the use of other drugs. For example, valproic acid can inhibit the process of glucuronidation of lamotrigine, which may lead to an increase in its serum concentrations and a longer half-life. This interaction could elevate the risk of toxicity. On the other hand, unlike some other anticonvulsant medications, lamotrigine's metabolism is not significantly influenced by enzyme inducers such as phenytoin, phenobarbital, rifampin, carbamazepine, or St. John's wort. In cases of overdose, the pharmacokinetic properties of lamotrigine play a role in the potential for toxicity. At high doses, the pathway responsible for metabolizing lamotrigine through glucuronidation may become saturated. This saturation can result in slower elimination of the drug from the body and an increase in its serum concentrations. Additionally, the relatively long half-life of lamotrigine may be further extended during overdose scenarios, which prolongs exposure and increases the risk of adverse effects. Several mechanisms contribute to the toxic effects of lamotrigine. One significant factor is the loss of selectivity for sodium channels. At toxic concentrations, lamotrigine not only loses its specificity for neuronal sodium channels, but can also block sodium channels in the heart. This blockade can result in severe cardiac conduction abnormalities, including complete heart block, which can potentially lead to death. Another mechanism involves channelopathies, which are genetic mutations affecting ion channels. Individuals with underlying channelopathies may experience more pronounced toxicity from lamotrigine, especially since they are predisposed to cardiac arrhythmias. Interestingly, despite its anticonvulsant properties, overdose of lamotrigine can paradoxically induce seizures. The exact mechanism behind this phenomenon is not fully understood. However, it may involve the downregulation of gamma-aminobutyric acid type A receptors and the upregulation of glutamate receptors, leading to increased neuronal excitability. Lamotrigine toxicity can also affect multiple organs. It can cause bone marrow suppression, liver tissue necrosis, inflammation of the pancreas, and hypersensitivity reactions. These diverse toxic effects highlight the importance of careful monitoring and management when using this medication. The clinical presentation of toxicity caused by lamotrigine can vary widely, primarily affecting the central nervous and cardiovascular systems. Symptoms related to the central nervous system include neurological abnormalities such as ataxia, altered mental status, dizziness, lethargy, and seizures. In severe instances, an overdose of lamotrigine may result in status epilepticus, a life-threatening condition characterized by prolonged or recurrent seizures. Additionally, movement disorders such as myoclonus, choreiform movements, and spasticity have also been reported in cases of toxicity. The cardiovascular system can be affected by overdose of lamotrigine, which may lead to various cardiac rhythm disturbances caused by sodium channel blockade. These disturbances include a widening of the QRS complex on an electrocardiogram, indicating delayed ventricular depolarization. Additionally, the QT interval can be prolonged, increasing the risk of potentially fatal ventricular arrhythmias. A specific pattern seen on electrocardiograms associated with lamotrigine overdose resembles the Brugada pattern, which is linked to an increased risk of sudden cardiac death. Moreover, the drug can impair conduction through the atrioventricular node, leading to bradycardia and, in some cases, complete heart block, which signifies a severe disturbance in normal heart rhythm. Severe overdose of the medication lamotrigine can lead to a critical medical condition known as cardiovascular collapse. This condition is characterized by a significant decrease in blood pressure, known as hypotension, and can result in shock. Prompt medical attention is crucial to manage and treat this life-threatening complication. Other organ systems can be affected by lamotrigine, with several serious adverse effects reported. Hepatic toxicity has been observed, including cases of both fatal and non-fatal liver cell death, even when the medication is taken at therapeutic doses. The drug can also provoke severe hypersensitivity reactions, which may involve multiple organ systems. One such reaction is drug rash with eosinophilia and systemic symptoms, a potentially life-threatening condition characterized by fever, rash, swollen lymph nodes, and involvement of various organs. Another hypersensitivity reaction associated with lamotrigine is anticonvulsant hypersensitivity syndrome, which carries a high risk of mortality. Severe skin reactions such as Stevens-Johnson syndrome and toxic epidermal necrolysis have also been reported and can be life-threatening. Additionally, acute pancreatitis has been linked to overdose of lamotrigine. The management of lamotrigine overdose primarily involves supportive care and addressing the specific symptoms presented by the patient. Ensuring airway and breathing support is crucial. This includes maintaining adequate oxygenation and ventilation, with intubation and mechanical ventilation considered if necessary. Seizures and status epilepticus are common concerns, and the first-line treatment involves the use of benzodiazepines. Managing hypotension may require intravenous fluids and vasopressors to support blood pressure levels. If cardiac dysrhythmias occur, treatment should be tailored to the specific type of arrhythmia identified. Sodium bicarbonate can be used to prolong the duration of the QRS complex in cases where this is affected. Gastrointestinal decontamination might be beneficial if activated charcoal is administered early after ingestion, with multiple doses potentially offering increased benefit by reducing absorption. Intravenous lipid emulsion therapy has shown promise in reversing severe cardiovascular toxicity, especially in cases that do not respond to standard treatments. Although hemodialysis and hemoperfusion are generally not recommended for managing lamotrigine overdose due to the drug's high protein binding, these methods may be considered in severe cases involving prolonged coma or rising drug levels despite multiple doses of activated charcoal. Finally, providing organ support is essential. This includes monitoring liver function, managing electrolytes carefully, and treating any hypersensitivity reactions that may occur. While lamotrigine crosses the placenta, many recommend treating pregnant patients in the same manner as non-pregnant patients, prioritizing maternal stabilization. The benefits of maternal survival without hypoxia or hypoperfusion outweigh the potential risks to the fetus. However, it is important to note that lamotrigine has been associated with a potential risk of orofacial clefts. Although a large case control study did not find a significant increase in overall birth defects, caution remains advisable. Elderly patients may have a reduced ability to perform glucuronidation, a process that metabolizes lamotrigine. This reduction can lead to a prolonged half-life of the medication and increase the risk of toxicity. In cases of renal impairment, the elimination of lamotrigine is not significantly affected. Toxicity from lamotrigine overdose can result in serious complications, mainly involving the central nervous system and cardiovascular system. Early recognition of overdose symptoms and prompt, aggressive supportive care are vital for effective management. In cases of severe cardiovascular toxicity, the use of intravenous lipid emulsion therapy may be considered, although further research is needed to confirm its effectiveness. Levetiracetam is a second-generation anticonvulsant medication primarily prescribed for treating various types of seizures. It is recognized for having a relatively favorable safety profile and is generally well tolerated compared to other medications used to control epilepsy. However, like all drugs, levetiracetam can cause adverse effects, especially in cases of overdose. The exact mechanism by which levetiracetam exerts its therapeutic effects is not fully understood. Nonetheless, it is believed to act through multiple pathways. One such mechanism involves the inhibition of voltage-dependent calcium channels, which reduces calcium influx into neurons, potentially decreasing neuronal excitability. Additionally, levetiracetam may enhance the effects of gamma-aminobutyric acid, the primary inhibitory neurotransmitter in the brain, thereby facilitating inhibitory transmission. It also appears to reduce the flow of delayed rectifier potassium current, another factor that could contribute to decreased neuronal excitability. Furthermore, levetiracetam may bind to specific synaptic proteins, modulating neurotransmitter release. While these mechanisms are responsible for its beneficial effects, they can also play a role in toxicity when the drug is taken in high doses. In cases of overdose, the most common clinical presentation involves depression of the central nervous system. The severity of this depression can vary from mild drowsiness to severe coma, which may necessitate medical interventions such as intubation and mechanical ventilation. Other neurological symptoms that have been reported include ataxia, vertigo, and confusion. Cardiovascular effects are generally not expected with levetiracetam overdose. However, there has been a case report of a patient who ingested lacosamide, cyclobenzaprine, and levetiracetam and subsequently experienced cardiac sodium channel blockade. It remains unclear whether levetiracetam contributed to this cardiovascular effect or if it was primarily caused by the other medications involved. Certain factors may increase the risk of significant toxicity from levetiracetam. The dose of the medication is a crucial factor, as higher doses are more likely to result in toxicity. Ingesting a large amount of the drug can lead to severe central nervous system depression and potentially life-threatening complications. Renal impairment also plays a significant role in toxicity risk because levetiracetam is mainly eliminated unchanged through the urine. Patients with compromised kidney function may have prolonged elimination times, heightening the risk of toxicity, especially sedation. Age is another factor. Elderly patients, particularly those with impaired renal function, may be more susceptible to prolonged sedation following an overdose of levetiracetam. The management of a levetiracetam overdose primarily involves providing supportive care. In cases of ingestion, gastrointestinal decontamination can be achieved through the administration of activated charcoal within 1 hour to reduce the absorption of the drug. Patients should be closely monitored for signs of central nervous system depression and respiratory depression. In severe instances, mechanical ventilation may become necessary to support breathing. Enhanced elimination methods, such as hemodialysis, can be effective in removing levetiracetam from the bloodstream. However, this procedure is rarely required because the drug typically has a short half-life and the toxicity experienced is usually mild. Hemodialysis might be considered in cases involving a large overdose, renal failure, or profound coma with high serum concentrations of levetiracetam. The overall prognosis for individuals who overdose on levetiracetam is generally favorable, with most experiencing mild and self-limiting symptoms. Deaths directly attributed to levetiracetam overdose are extremely rare. Nevertheless, serious complications such as respiratory depression and coma can occur if an individual ingests a large amount of the drug. Early recognition of symptoms and prompt supportive care are essential to achieve the best possible outcomes in such cases. This summary provides an overview of important antiepileptic medications, their mechanisms of action, and key toxicological considerations that are relevant for pharmacy professionals. Antiepileptic drugs use a variety of mechanisms to control seizures. One common mechanism is the blockade of voltage-gated sodium channels. By inhibiting these sodium channels, the release of glutamate is prevented, which reduces the excitability of nerve cells. Many antiepileptic drugs, including carbamazepine, lamotrigine, phenytoin, and valproic acid, work in this way. Another mechanism is the blockade of voltage-gated calcium channels. This action reduces the release of excitatory neurotransmitters. Medications such as gabapentin, pregabalin, lamotrigine, topiramate, and zonisamide use this mechanism. Although levetiracetam also acts on calcium channels, this is not its primary effect. Some antiepileptic drugs directly inhibit the action of excitatory neurotransmitters. For example, perampanel acts as an antagonist of the alpha-amino 3-hydroxy-5-methyl-4-isoxazolipropionic acid receptor. Topiramate inhibits kainate receptors, and valproic acid blocks N-methyl diaspartate receptors. Another strategy involves enhancing the activity of gamma-aminobutyric acid, the main inhibitory neurotransmitter in the brain. Vigabatrin and valproic acid achieve this by inhibiting the enzyme gamma-aminobutyric acid transaminase, while tiagabine increases levels of gamma-aminobutyric acid by inhibiting its reuptake. Levetiracetam is unique in that it binds to synaptic vesicle glycoprotein 2A, a protein involved in the release of glutamate. By binding to this protein, levetiracetam helps inhibit the exocytosis of glutamate from nerve terminals. Finally, some antiepileptic drugs act by opening voltage-gated potassium channels, which reduces the excitability of nerve cells by causing the membrane to become more negatively charged. Ezogabine works in this way. It is also worth noting that some antiepileptic drugs, such as valproic acid and topiramate, have multiple mechanisms of action. Valproic acid toxicity can result in elevated ammonia levels in the blood, a condition known as hyperammonemia. This occurs due to several mechanisms, including mitochondrial dysfunction, depletion of carnitine, and interference with the urea cycle. Metabolism of valproic acid uses up L-carnitine, which is essential for transporting fatty acids into the mitochondria for energy production. When carnitine becomes depleted, valproic acid metabolism shifts to omega-oxidation, leading to the formation of toxic metabolites such as 4N-valproate. These metabolites can inhibit the enzyme carbamoyl phosphate synthase I and reduce the body's ability to detoxify ammonia. Supplementation with L-carnitine helps restore normal levels, promotes the preferred beta-oxidation pathway, reduces omega-oxidation, and supports the urea cycle to improve ammonia elimination. In acute cases, intravenous L-carnitine is preferred because it offers much higher bioavailability and avoids first-pass metabolism by the liver. Oral L-carnitine is less efficiently absorbed, and its absorption becomes saturated at higher doses. For patients with symptoms, the recommended intravenous loading dose is 100 milligrams per kilogram of body weight, with a maximum of 6 grams, administered over 30 minutes. This is followed by 15 milligrams per kilogram intravenously every 6 hours, up to a maximum of 6 grams per day for adults. Patients without symptoms may receive oral L-carnitine at 50 to 100 milligrams per kilogram per day, divided into several doses, with a maximum total dose of 3 grams per day. Phenytoin is an antiepileptic drug that has been in use since 1938. It is generally considered safe when taken by mouth, but intravenous administration carries a higher risk of toxicity, mostly due to the use of propylene glycol as a diluent. When phenytoin is taken orally, absorption is slow and incomplete. The drug is highly bound to plasma proteins, with about 90% attached to albumin, and only the unbound fraction is active. Metabolism occurs in the liver by cytochrome P450 enzymes, primarily CYP2C9 and CYP2C19. At low concentrations, phenytoin is metabolized according to first-order kinetics, but as concentrations rise and the enzymes become saturated, metabolism shifts to zero-order kinetics, which significantly prolongs the drug's half-life. The primary mechanism of phenytoin toxicity is the prolongation of sodium channel inactivation in nerve cells. At higher concentrations, phenytoin also inhibits adenosine reuptake and can delay potassium channel activation. Signs and symptoms of phenytoin toxicity vary depending on the dose, duration, route, and rate of administration. Nystagmus, or involuntary eye movement, is usually the earliest sign and is seen at or above 20 micrograms per milliliter. Ataxia and central nervous system depression are more likely at levels above 30 micrograms per milliliter. Severe cases, often with concentrations greater than 50 milligrams per liter, may involve lethargy, slurred speech, abnormal movements involving the pyramidal or extrapyramidal systems, and paralysis of the eye muscles. Paradoxical seizures, though rare, can occur at concentrations above 30 micrograms per milliliter. Measuring the free, unbound concentration of phenytoin is more accurate for assessing toxicity in certain populations, and symptoms typically appear at or above 2 micrograms per milliliter of free drug. Rapid intravenous administration of phenytoin can cause low blood pressure, slow heart rate, and electrical conduction abnormalities in the heart, all of which are attributed to the propylene glycol solvent. Such effects are rare with oral overdose. Other adverse effects include tissue damage at the injection site if the drug leaks outside the vein, chronic overgrowth of the gums, and a rare hypersensitivity syndrome related to anticonvulsant use. Treatment of phenytoin toxicity is mostly supportive. Early administration of activated charcoal may be beneficial. Hemodialysis and hemoperfusion are generally ineffective because of the drug's high protein binding. Seizures are typically managed with benzodiazepines or barbiturates. Low blood pressure after intravenous administration is treated with intravenous fluids, and slow heart rates may require atropine or temporary cardiac pacing. Fosphenytoin is a pro-drug of phenytoin, offering improved water solubility and reduced toxicity, which allows for faster rates of intravenous infusion. Carbamazepine is an antiepileptic drug that has a chemical structure similar to that of tricyclic antidepressants. Its primary mechanism of action is the blockade of voltage-gated sodium channels, which reduces neuronal excitability. Carbamazepine also acts as an antagonist at acetylcholine, N-methyl diaspartate, and central nervous system adenosine A1 receptors, and these additional effects contribute to its toxicity profile. The absorption of carbamazepine when taken by mouth is slow and unpredictable, and it can take up to 100 hours to reach peak blood concentrations. The drug is lipophilic and is extensively metabolized in the liver by the enzyme cytochrome P453A4. The major active metabolite, carbamazepine 10,11 epoxide, also contributes to toxicity. Carbamazepine has the unique property of inducing its own metabolism after 2 to 4 weeks of therapy, a process known as autoinduction. Carbamazepine toxicity is further complicated by delayed and prolonged absorption, accumulation of the active metabolite, and concentration-dependent protein binding. This means that in overdose, there's more unbound, active drug circulating in the body, which increases toxicity risk. There are several important drug interactions to consider. Inhibitors of cytochrome P453A4, such as macrolide antibiotics and azole antifungal agents, can increase carbamazepine levels. Inducers of the same enzyme, including phenytoin and rifampin, decrease carbamazepine levels. In addition, inhibitors of epoxide hydrolase, such as valproic acid and lamotrigine, can increase levels of the toxic metabolite. The clinical manifestations of carbamazepine toxicity are broad. Effects on the central nervous system can include involuntary eye movements, nystagmus, loss of coordination, ataxia, seizures, coma, and abnormal movements known as dystonic reactions, especially in children. Cardiovascular effects often occur early and are related to anticholinergic activity, leading to symptoms such as delirium, agitation, increased heart rate, slowed digestive tract movement, and urinary retention. Although carbamazepine is structurally similar to tricyclic antidepressants, dangerous sodium channel blockade in the heart, which can cause QRS complex prolongation on the electrocardiogram, is less common. However, heart block, slow heart rate, rapid heart rate, and low blood pressure may still occur. In severe overdoses, respiratory depression and coma can develop. Other possible complications include low blood sodium levels as a result of the syndrome of inappropriate antidiuretic hormone secretion, decreased white blood cell count, temporary elevation of liver enzymes, and a hypersensitivity syndrome related to anticonvulsant use. Treatment of carbamazepine toxicity is primarily supportive. Airway protection is a priority, and multiple doses of activated charcoal may be beneficial to enhance elimination. Seizures are managed with benzodiazepines or barbiturates. Low blood pressure is treated with intravenous fluids or vasopressors, and low blood sodium is managed with fluid restriction. In severe cases, hemodialysis or hemoperfusion may be considered, even though carbamazepine is highly protein-bound. Oxcarbazepine is a structural analog of carbamazepine. Both drugs block voltage-gated sodium channels, but carbamazepine also has additional receptor antagonism. Oxcarbazepine is a prodrug that is metabolized to its active form, 10-monohydroxycarbamazepine. Compared with carbamazepine, oxcarbazepine is absorbed more rapidly and completely. While carbamazepine is metabolized by cytochrome P453A4 and induces its own metabolism, oxcarbazepine undergoes reduction and glucuronidation and does not significantly affect cytochrome P450 enzymes. Oxcarbazepine also has a much shorter half-life than carbamazepine. Both carbamazepine and oxcarbazepine can cause central nervous system depression, cardiovascular depression, and respiratory depression. Carbamazepine is more likely to cause seizures. Serious cardiovascular complications are less commonly seen with oxcarbazepine overdose. However, oxcarbazepine is more frequently associated with low blood sodium, which can occur in up to nearly 30% of cases. Treatment of oxcarbazepine toxicity is also primarily supportive. Activated charcoal is recommended to reduce absorption if administered early. Extracorporeal elimination, such as dialysis, is not effective for oxcarbazepine because its active metabolite is formed rapidly and is not easily cleared from the body. Lamotrigine exerts its therapeutic and toxic effects by acting on ion channels and neurotransmitters. Its primary mechanism involves blocking voltage-gated sodium channels in their inactive state, which stabilizes neuronal membranes and reduces excitability. Lamotrigine also inhibits presynaptic N-type and P/Q-type voltage-gated calcium channels, leading to decreased release of glutamate, an excitatory neurotransmitter. When taken by mouth, lamotrigine is rapidly and almost completely absorbed, with a bioavailability of about 98%. It is metabolized in the liver through glucuronidation, and its half-life ranges from 24 to 37 hours. Drug interactions are important to consider. Valproic acid inhibits the glucuronidation of lamotrigine, which increases its concentration in the blood and the risk of toxicity. However, enzyme-inducing drugs do not significantly impact the metabolism of lamotrigine. At high doses, the process of glucuronidation may become saturated, resulting in slower elimination of the drug and a prolonged half-life. Toxicity from lamotrigine occurs when it loses its selectivity for neuronal sodium channels and begins to block cardiac sodium channels as well. This can result in severe abnormalities of cardiac conduction, including complete heart block. Paradoxical seizures may also develop, possibly due to downregulation of gamma-aminobutyric acid GABA receptors and upregulation of glutamate receptors. In addition to neurological and cardiac effects, lamotrigine toxicity can cause multi-organ involvement, such as bone marrow suppression, liver cell death, pancreatitis, and severe hypersensitivity reactions. Clinically, patients may develop unsteady gait, changes in mental status, dizziness, drowsiness, seizures, persistent seizure activity, known as status epilepticus, and various movement disorders. Cardiac complications can include a range of abnormal heart rhythms, such as prolonged QRS or QT intervals, Brugada-like patterns on the electrocardiogram, and different types of heart block, all of which can potentially lead to cardiovascular collapse. Other serious adverse effects include liver cell death, hypersensitivity reactions such as drug reaction with eosinophilia and systemic symptoms stress, Stevens-Johnson syndrome and toxic epidermal necrolysis, and inflammation of the pancreas. Treatment of lamotrigine toxicity is primarily supportive. This includes supporting the airway and breathing, using benzodiazepines to control seizures, giving intravenous fluids or vasopressors for low blood pressure, and providing targeted treatments for abnormal heart rhythms, such as sodium bicarbonate for QRS prolongation. Activated charcoal may be considered if the patient presents early after ingestion. In severe cases of cardiovascular toxicity that do not respond to standard treatments, intravenous lipid emulsion therapy may be helpful. Hemodialysis and hemoperfusion are generally not recommended. Levetiracetam is a second-generation anticonvulsant medication recognized for its overall favorable safety profile. Toxicity with levetiracetam involves several mechanisms, including inhibition of voltage-dependent N-type calcium channels, enhancement of gamma-aminobutyric acid-mediated inhibitory transmission, reduction of delayed rectifier potassium current, and binding to synaptic proteins. The primary clinical manifestation of levetiracetam toxicity is depression of the central nervous system, which can range from mild drowsiness to deep coma. Cardiovascular effects are uncommon. Certain factors increase the risk of toxicity, such as large doses, massive overdose, and impaired kidney function, since levetiracetam is mainly eliminated by the kidneys. Elderly patients may also be more prone to prolonged sedation. Management of levetiracetam toxicity is mainly supportive. Activated charcoal can reduce absorption if given within an hour of ingestion. Careful monitoring for central nervous system and respiratory depression is essential. Although hemodialysis can effectively remove levetiracetam from the body, it is rarely necessary and is reserved for cases of massive overdose, kidney failure, or profound coma. The overall prognosis is very favorable, with most patients experiencing mild and self-limiting symptoms. Deaths are extremely rare, but severe complications such as respiratory depression and coma can occur with very large ingestions.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.